The time is now 12:30. It's the official start time for today's broadcast. Using Telepsychiatry to Improve Access to Evidence-Based Care with Dr. Sai Saeed. And now, without further ado, I'd like to turn things over to your host today.
Thank you. Hello, and welcome to Aligned Quality Learning and Action Network for improving the identification of depression and alcohol use disorders in primary care. As Aligned Quality's Behavior Health Task Lead, I would like to extend my appreciation to you for participating in today's learning event and for your commitment to improving the behavioral health outcomes of the patients you serve. Before we begin with today's presentation, I would like to remind you that in addition to our free monthly webinars, we also provide free evidence-based tools, resources, and technical assistance to help you enhance your service delivery and operational efficiencies. I encourage you to take advantage of these opportunities and to frequently engage with us to share your thoughts, experiences, and best practices. And now it's my honor to introduce our featured speaker, Dr. Sai Saeed. He serves as the North Carolina Director of the statewide Telepsychiatry program and serves as a chairman of the Department of Psychiatry and Behavior Medicine at East Carolina University. He is also Chief of Psychiatry at Vidant Medical Center. He is also Chief Psychiatry at Vidant Medical Center. Dr. Saeed is the Editor-in-Chief of the Journal of Psychiatric Administration and Management, and it's published in the areas of evidence-based practices, anxiety and mood disorders, psychiatric treatment integration, and telepsychiatry. Welcome, Dr. Saeed.
Thank you, Matthew. Appreciate the kind introduction. So I will spend about 20 minutes talking about using telepsychiatry, and of course the focus is on psychiatry, but I'll make a few comments about its utility in other fields as well. So here are my objectives to talk about telemedicine in general and telepsychiatry specifically. Talk about how telepsychiatry can improve access to mental health care in rural and remote area, as well as a few comments about the required technology in using telemedicine and telepsychiatry. So with this slide, the message that I would like to send is that there was a time that telemedicine was probably premature, and many of the stars were not lined up as they have been currently. So we have seen the focus with the healthcare reform, with the PPACA, with the Accountable Care Organization. We have electronic medical records that facilitate its use, ICD-10, and then on the horizon, ICD-11 has changed some of the context and the backdrop. Of course, we are in the phase of meaningful use, and depending on your organization, you may be more advanced in this, patient care, medical homes, and the list goes on. So many of the stars have been lined up and create just the right climate for utilizing telemedicine. We know that mental disorders are common. The estimate is about 1 in 4 people, adult 18 years and older, have a diagnosable psychiatric condition. And while this number may seem very high, and indeed it is high because it also includes conditions like simple phobias, minor anxiety, and minor depression, the question usually comes up, so what is the number that represent people who have severe mental illness who would require ongoing care for this, just like a patient with diabetes, hypertension, or any other chronic medical condition would. And that number is estimated to be about 6% of the population, 1 in 17, or over 14 million people. So still a lot of people who suffer from this severe and persistent mental illness, one or the other type, and they would require ongoing care. So with this, the next question that comes up, that if these illnesses are that common, do we have the workforce ready to provide care for this? Now, this is the slide that shows how many psychiatrists we have state by state across the nation. And I certainly don't intend to imply as if psychiatrists are the only one that care for people with mental disorders, because it's well established that about 80% of depression gets treated by primary care doctors. There are many non-physician providers who also care for various types of mental disorders. The reason I'm using psychiatrists here for this slide is that I'm focusing on people who have severe and persistent mental disorder, and this is the population that is, as I showed in the previous slide, about 6% of the population, and this is a group that indeed require care by psychiatrists. So that's the logic behind that. As a general rule, it's agreed upon that the number of psychiatrists to provide at least bare minimum care is 1 in 10,000 population. So the state where I'm in, the average number is 1.16. The highest in the nation is Washington, D.C., which is 6.48 per 10,000, followed by Massachusetts, which is 3.10. And then you can see that most of the nation is hovering somewhere between 1.5 or so. So looking at this, at one conclusion one might draw is that, well, so we have at least a bare number of psychiatrists. The problem, unfortunately, is that this is average statistic, and when you look at different states, county by county, you start to see a picture not too different from my own state here, North Carolina, where you can see that the number of these psychiatrists is distributed unevenly, which is the case nationwide. So if you look at any physician group, I think this number would generally hold true. So for example, here in North Carolina, in this slide, the white area represents where there are no psychiatrists. Dark colors are good. And you can see that there are very few counties which meet that definition of having at least 1 in 10,000 psychiatrists. And by far, the majority of these of the counties do not. And that number, if you look at that overall summary from the previous slide, 29 out of 100 counties in North Carolina have no psychiatrist. 58 out of 100 counties have a shortage of mental health services. And I'll submit to you that this number holds generally true for most of the states. So any state you pick, and you would notice that physicians in general are vastly represented in those counties which have a population density, which makes sense from an economic standpoint, because if you are in one of the counties which is very sparsely populated, it would be very, very hard to really make it work and support the expenses associated with that kind of a clinical care. So the problem becomes then when you go to the county level, many of the counties will not have physicians in general and psychiatrists in particular. So the next question becomes that, so if you don't have enough workforce, where would the patient go? And with this, what we have started to notice is that many of these patients start utilizing emergency department to provide, to get the care that they need. And in recent years, in the last 3 years in North Carolina, we have seen that the number of patients who utilize emergency department for care has literally doubled. On an average, nationwide, 5% of the population that present in an emergency department are there for a mental health reason. In North Carolina, in 2010, that number was exactly double of that, about 10%. So what happens when you show up in emergency department? The next question is, well, do you get the care that you are seeking? And this is the data from North Carolina again, from 2012, which showed that if a patient showed up in an emergency department, if they needed to be hospitalized for severe and persistent mental illness in a state psychiatric facility, they were waiting on an average someplace about like 78 hours. If they were going to be admitted to a state alcohol and drug abuse treatment center, that wait was 33 hours, and for a bed in a community psychiatry unit, it was 27. So in all of those cases, it was more than a day. And of course, this is an average. And we have seen many, many cases where the patient was in an emergency department for days, and especially if it was a child or an adolescent. That wait sometime was in weeks, not in days or hours. So that's the problem. We have disorders which are relatively common. For severe illnesses, that number is about 6%. There's a shortage of psychiatrists. When you drill it down to the county level, on a national level, there are many, many counties that do not have psychiatrists. Patients end up using emergency department for getting care for acute crises. But when they show up in emergency department, they have to wait long hours. And it's not just for the patient and family inconvenience, it's also the throughput for emergency departments. So in places where the resources are precious, and especially for a smaller emergency departments, if a bed gets tied up for days on end, of course, their ability to provide care for other medical emergencies directly proportional to that. So the premise of this talk is that telepsychiatry can provide help in situations like that. Now, for the purpose of this talk, I'm using the definition of telepsychiatry, which is utilized by most of the third-party payers as well as by CMS. And in this definition, telepsychiatry is live, interactive, real-time audio-video conferencing. It does not include things like communication with a patient on a telephone. It does not utilize a store and forward technology. It has to be in real time. There has to be an audio as well as video connection, and it has to be interactive in real time. The reason why I'm emphasizing that is that the definition of telemedicine, which is utilized by World Health Organization, includes things like store and forward, as well as the telephonic communication as examples of telemedicine. But many of the third-party payers will not cover that service if telephone is being used or if it's a store and forward, which is not uncommon in specialties like radiology or pathology. So this is interactive real-time. There are many benefits which are associated with use of telepsychiatry. Our group looked at that literature, which is the last 50 years, and published that a few years ago about what are the demonstrated benefit, meaning that behind each and every of the assertion on this slide, there is at least one study that backs it up. And at that time, what we summed up is that telepsychiatry enhances access to mental health services, as well as many other services in the broader area of telemedicine. It reduces geographical health disparities. It certainly makes it convenient for the patient to get care closer to their home. It reduces professional isolation. And then there are things which are not as well documented as other, for example, help with dealing with stigma associated with receiving care for mental health problems. So there are many of these demonstrated benefits for telepsychiatry. It's not just a concept to deal with rural area, but now there is more and more literature being produced about telepsychiatry and telemedicine, improving efficiency of care that's being provided, expanding service delivery, as well as improving treatment outcome by standardizing care, as well as the measurement system. There are many clinical applications for e-mental health or telepsychiatry. For example, it could be utilized for diagnostic as well as therapeutic approaches. Forensic sector has a fairly large presence in that arena. The point of delivery can be anywhere where actually equipment could be provided and patient could have access, such as hospitals, emergency departments, outpatient clinic, physician offices, even homes, as well as nursing homes, schools, and prisons. The common application include pre-hospitalization assessment, as well as post-hospitalization follow-up, outpatient care, both psychotherapy and medication management, as well as providing consultation. The utility could also be a quote-unquote curbside consultation, where a physician can consult with a psychiatrist without psychiatrist interviewing the patient. The basics about what needs to take place before telepsychiatry can go live. At the least, what we need is a video camera, microphone, speakers, and 1 or 2 displays. For example, in this graphic, which you're looking at, the physician looking at here actually at 4 monitors. This is an obstetrician, so you can see the ultrasound coming on 1 monitor. There's an EMR open in the other one. Here is a patient, and then here the physician is looking at completing the notes and these documentation. In terms of the equipment, the most important thing in the utility of telepsychiatry is to make sure that confidentiality is maintained. Historically, what has been used for this is what was being referred to as codec, which is compression-decompression device. It could be built into the piece of equipment, or it could be a separate device. And what it does is that the incoming as well as outgoing signals are decompressed and decrypted, mostly to deal with the confidentiality aspects of that. Probably one of the more common questions that come up in that relationship to is that nowadays, when we live in times like Skypes and Facebook, that there are a lot of other applications on the internet available for us to do in audio-video conference. And the question comes up, are these appropriate uses for clinical settings? And in general, the answer is that if such connection utilize a technology which basically meets all the HIPAA standard, then that could be utilized. Unfortunately, both Facebook, FaceTime, as well as Skype currently are not up to that par with that, and many of the organizations, including my own, will not utilize that for clinical applications. There are both fixed devices, which could be a desktop as well as mobile cards. So what you can see in this device that I'm pointing out with my monitor, here is you can notice that there are no cables, and this is a completely mobile card. The only time there's a cable coming out of that is when it's hooked to the wall for recharging. But this is a card, for example, the one we use in emergency department setting, where it could be moved from bay to bay. To make it convenient for the staff, so that the patient doesn't need to be moved to a particular room that's assigned for that. It's a good idea to have a tilt and zoom technology available, which can focus in the different parts of the interview, as well as give you, as well as a patient, a feel about who else may be quote-unquote listening in. As a routine, when I start a clinical contact with a patient, I would move the camera around to let the patient get a feel for who is available in the room. For example, at time I may have resident or medical student, so that the patient is at ease with that this is something which is not unlike a face-to-face encounter. So with that backdrop, when we started to see the problem on the statewide level in the state of North Carolina, when the patient was showing up in the emergency department to get services for their crisis, at that time, we were invited by the Department of Health and Human Services to develop a program that may help deal with that problem. That proposal was written, a program was developed, which was actually funded in the 2013 session of the legislators, providing funding for statewide telepsychiatry program, NC STEP for short. The goal of that program was fairly straightforward, which was that if a patient shows up in an emergency department that does not have access to a psychiatrist, this program would simply step in and would take care of that patient for psychiatric consultation. Since then, in 2013, the program has grown leaps and bounds. So on this map, the darker color that you're looking at, these are the counties where the program is live. The lighter color shows where we are in a process of bringing on these hospitals. So by the end of this year, as you can see that this program has a very robust footprint throughout the state of North Carolina. There are very, very few counties which are not part of this program, which is by design, because these are the places where large medical schools and university settings are located, and they have their own 24/7 availability of psychiatrists for that purpose. Since the program inception, we have seen over 20,000 encounters, and of course, it's still growing. Our estimation is that once all of these hospitals are run live, we would be seeing roughly about 24,000 encounters a year. And this gives you in one glance a feel for that what we do with these patients, how many patients show up with involuntary commitment. And we have been very successful in actually finding care for these patients without having to keep that involuntary commitment. On an average, as many as a fourth of these patients who show up with an involuntary commitment do not require to be maintained on those IVCs. So from that standpoint, that has been successful. And that by itself has been a huge saving for the state for in all different areas, both Medicaid, Medicare, as well as third-party payers, saving somewhere around $5 million a year. So there has been a huge return on investment. Of course, the main benefit of the program is convenience for the patient and families, for the communities, as well as for the hospitals where the program has directly impacted the throughput for these patients. So I know I went through many of these things very rapidly to give you a very global view of telepsychiatry. And what I've said so far is that telepsychiatry clearly is a viable and reasonable option for providing psychiatric care to those who lack access to these services. Our technology has come a long way from those jerky, blurry, fuzzy pictures that nowadays what the technology we have is adequate for most of the users, and it continues to advance. The barriers that lie in the game of implementation will require a combination of consumer, provider, and governmental advocacy for that. And at this time, although it may seem like we are talking about technology and all of those things, it is still about relationship between the patient and the provider, relationship between the referring provider and the consulting providers, and many of the other entities in between. It is still about relationship and not technology.
Thank you, Dr. Saeed, for a terrific presentation. I'd now like to open things up to Q&A. So if you have questions, please chat them in to all panelists, and I'll verbalize them for Dr. Saeed. All right. So it looks like I have one question here, Dr. Saeed. Is there evidence supporting that telepsychiatry is as good as face-to-face encounters?
Yes. The research that I cited earlier, including work done from our own lab here, has looked at these questions. And of course, the usual comparison is care that's being provided via telemedicine or telepsychiatry versus face-to-face. And most of that research encompassing the past 2 to 3 decades has concluded that the care provided via telepsychiatry is as effective as the one which is provided face-to-face. And I have a reference, actually several references in this presentation, including the 50-year review that our group published in 2011 that summarizes that research.
Thank you. Those are valuable resources. Got another question here. Related to that, what is the reaction of patients and providers to telepsychiatry services?
So interestingly, the objections that, maybe objection is too strong a word, but people who tend to hesitate using telepsychiatry tend to be more on a provider side than the patient. The provider's reaction have been mixed, anything from this is impersonal, it takes a personal touch away, and technology and the cost of technology, those are the common areas. The acceptance has been fairly high on patient and family side. And I'll tell you that our own experience of running this statewide telepsychiatry program, having seen 21,000 patients in crisis with severe conditions like acute mania, acute psychosis, paranoia, and the list goes on. We have not had any patient that have refused utilizing telepsychiatry as a service. So the acceptance, I would say, has been fairly high.
Thank you. That's great feedback and news. One more question here. Does insurance cover telepsychiatry services?
Yes, most of the third-party payers, including Medicaid and Medicare, would cover that. The codes utilized for that are the same as face-to-face, with basically a qualifier in the end, which indicates that the service was provided by telepsychiatry or Telelink. Who can bill for that is limited based and varies from state to state. As a general rule, physicians, psychiatrists, PhD level psychologists, and in some states, licensed clinical social workers can bill for services.
Good news. Thanks for that update. Looks like we have time for just one more question, and this one we could devote an entire session to this, but what are the privacy issues around using these tools?
So, of course, the most important issue is that same provisions of HIPAA applies to clinical encounters. So we need to make sure that all the HIPAA provisions are met. The interesting or the unique challenges with telepsychiatry is that there are others who may be, quote unquote, listening into the session, and that needs to be dealt with. Commonly, the patient wonder about whether the session is being recorded, and of course it's not unless it's specifically asked for that, and the patient needs to be informed about that. What I have found helpful in my clinical work is that before starting and delving into the clinical material, I actually use the camera to zoom in around my office to let the patient know who else is present and available in that office setting. And of course, it's also important to be aware of who on the patient end may be listening in. And same provisions apply. So, for example, in a face-to-face session, when the patient brings someone into the session, it's always important to make sure that we are not just relying on an implied consent that since the patient brought someone in, it must be okay with the patient, but actually explicitly ask. So the same kind of things apply in telemedicine and telepsychiatry setup.
Thank you, Dr. Saeed, for an excellent presentation. I'd like to thank you all for participating as well. Before we go, fill out the post-presentation evaluation to get your CE certification. If you have questions or concerns, please feel free to reach out to me using the contact information you see before you. I look forward to our continued engagement. The next webinar is scheduled for December 15th. More information will be sent to you shortly. Until then, take good care.
Thank you for joining the call today. This is Dr. Adrienne Mims, Vice President, Chief Medical Officer for Alliant Quality. As you see on the slide here, there are some screening codes that you can use to document that you are doing screening for Medicare beneficiaries for depression. These are available to primary care clinicians as listed there below. And there are several codes that can be used to indicate screening. We've also listed the amount that are charged in various areas of your state. Please use these codes. You deserve the reimbursement, and it documents the quality care that you are providing. Thank you.